Hi, everyone. Welcome to Dean's Chat, where we discuss all things podiatric medicine. My name is Dr. Jeffrey Jensen. I'm the Dean at the Arizona College of Podiatric Medicine and the host for the Dean's Chat podcast. With me, as always, my co-host, Dr. Johanna Richey. Hi, Joe.
Hi, Jeff. How you doing?
I'm doing fabulous. Good to see you. We have a phenomenal guest today from Chicago, Illinois, Dr. Jeff Baker. Jeff, welcome to Dean's Chat.
Thank you for having me. I really appreciate it.
Oh, thanks for joining us. You know, Dr. Baker, we're fairly informal here on Dean's Chat, and if it's okay with you, let's go with first names, Jeff and Joe and Jeff.
That works for me.
Fantastic. Thanks.
Well, thank you again, Jeff, for taking the time today to come talk with us and to our audience about your own experience as well as the residency program that you and fellowship, if I believe you have both types of learners in your program. Just to do a quick bio, Dr. Baker graduated from the Northeastern University in Boston, Massachusetts in 1992, and your degree is in athletic training and cardiovascular health and exercise, which is really interesting, and it'll be fun to get more information from your background. You also played varsity soccer while you were in college. Is that correct?
Yep.
Awesome. And you went on to do your podiatric medical school at Kent State University in Cleveland, Ohio, and then completed a 3-year surgical surgical residency program at St. Mary's Hospital in Hoboken, New Jersey, and then went on to do your fellowship program in reconstructive foot and ankle surgery at the Weil Foot Ankle Institute in Des Plaines, Illinois, which is where you currently are faculty staff. Is that correct?
Yep. So I'm still working there.
Still enjoying it, from what I've heard.
Yes, it's been very good. It's been many, many years, but it's been very good.
Good. And, you know, one of the things that I really enjoy about you, Jeff, was your enthusiasm and getting people really engaged with content, as we've had a couple different opportunities to interact. And so it's fun. As I was looking through your CV, you have like 5 pages of academic experience in terms of posters, presentations, research papers. But some of the things that I think are really unique and fun is some of the accolades that you have. You've been the president for the Midwest region for American College of Foot and Ankle Surgeons. And you're also got voted as the attending of the year for your residency program in 2006 and 2007. But currently you're also the chief medical officer. Is that correct?
Yeah, so a part of Weil Foot Ankle Institute recently merged with Balance Health, which is a big podiatric group in the Midwest, from the West Coast and now the Midwest. And so within how this is set up, there's different regions, and each of those regions will have a physician that is the regional chief medical officer. And so I'm the regional chief medical officer for the Chicago City region of Weil Foot Ankle Institute Balance Health. So there's 3 different offices. I have 8 doctors that work underneath me, and basically I'm sort of the physician liaison towards the corporate aspect of it, and our chief operating officer so I'm sort of like a representative in terms of government aspects of it. So I'm the regional chief medical officer. We have 3 of them in the Chicagoland area, and then multiple ones all over in the different aspects of the 7 states that we're in as this big podiatric medical group now.
That's fantastic. And as a faculty for the residency program, can we start by just talking a little bit about your residency program? A lot of our listeners are current students or prospective students. So if you can talk a little bit about the residency program, I know that's where a lot of their questions usually lie.
Yeah, so I used to be a part of a residency program at a small community-based hospital that was on the north side of the city of Chicago. And there I was the assistant residency director. And that residency program ended up closing. And so I was looking for somewhere else to go. And there's a level 1 trauma center that's on the north side of the city of Chicago, Advocate Illinois Masonic Medical Center, which had an excellent 3-year residency program. I looked to be a part of that as needing a new hospital, that I didn't want to stay at the hospital that didn't have a residency program anymore. And I wanted to be a part of a residency program. So I got on staff, and now it's been probably 13 years. So I'm now currently a core faculty within that. So there's a residency director, assistant residency director, Dr. Fleischer and Dr. Yorath. And then I'm just a core faculty, which I do 95% of my cases with the residents at the residency program at the hospital. And then we have teaching rounds every Tuesday morning where I am there, and we present all of the cases for that week in terms of pre-ops, and we go over all of the cases from the week before in terms of post-op. And we do that with the residents that are on service, plus whatever students that we have that month that are rotating through the hospital. So I've been doing that for a long time. It's very good to keep myself involved by being a part of a residency program, and especially the academic aspects of it, because we do teach the residents and go over these cases, but from hearing from the thought process on other attendings for how to do cases, even my own cases that we're presenting, I think it's kept me really going in terms of looking at ways to deal with things, how things have changed, how podiatric medicine has changed, different aspects of things. And it's been a very good marriage in terms of being there. I'm one of the only attendings. Now there's a second attending of court attendings that were trained outside of the Institute, which kind of it sometimes was a little bit interesting because I was coming from an East Coast trained and then fellowship trained aspect where most of the attendings were attendings who are core that did the residency program, trained there, and their whole life has just been advocate Illinois Masonic Medical Center. So it's been great. And there's been some procedures that they've done there for years that I've kind of taken on, learning later on in life in terms of my life. So it's been an excellent thing to always be in education and learning and progressing. So I think the residents get a lot out of it, but also I get a lot out of the residency program too.
Jeff, I'm sorry. I was a clerkship director at the North Colorado program when we first started it. And I learned that nothing keeps you on your toes more than working with students and residents.
Yeah. If you're not up to date on things, they will certainly let you know that you're not up to date on things. Usually they're very tactful on how they do it, but they kind of bring it out like, that's not how, we're learning and teaching and doing these things anymore, that there is progression, and progression is good. And I think it is difficult as especially in a private practice setting, if you're not in a training aspect of it, that there are a lot of people that do a very good job on that in our podiatric profession, but they have to work at it on their own. It is kind of like it's already baked into my schedule that I'm getting some of this. And like tomorrow morning we have journal club. So I'm kind of, for lack of a better term, forced to do it, but it is very difficult to keep up on things. It takes a lot of time. And when you're a part of a training program, it kind of helps you to be able to do that. And it feels a little bit more organic and natural.
How many residents do you guys take?
So we have 3 years and 3 residents per year. So there's currently 9 residents. 3 of them are out of Cook County Hospital, Stroger Hospital, which is one of the most probably famous sort of public health institutes in the country. And they get a lot of training there because it's just a lot of work. So they're thrown into the fire. And when we talk about pathology and seeing pathology, like our first year residency, pathology, like just unbelievable pathology working in that environment. And then the second and third years they spent at Illinois Masonic Medical Center on the north side of the city. And that's where I work with the residents. So I really, in our residence program, just how it happens to be set up, I don't work with the residents until their second and third year because they're not at the institution where we do our surgeries. That may switch in the future. We're looking into that, kind of having them move around so the first years aren't just locked into one area. But it's got some positives to it. They're really thrown to the fire. The old adage of teach a baby to swim by throwing it into the water. It's sometimes not the best thing, but it is sometimes a good thing, is that you're just exposure and it's like, we need you. It's busy. Day one, go. So I think there's a lot of positives about the residency program. probably the biggest positive about the residency program is its dedication to research. Dr. Fleischer, who is the residency director, has so many accolades in terms of his research and research that he's done. And the residency program presents manuscripts on a regular basis each year, 2 to 3 to 4, and is winning at the podium at the American College of Foot and Ankle Surgeons annual scientific conference each year. So there's, the residents do a lot, get a lot of surgical training, but there's a real significant research arm to the residency program, which really allows our residents when they graduate to be fully well-rounded in terms of everything and kind of understanding not only, this is how you do it, but why you do it this way.
Jeff, I think it's interesting because sometimes you get new residents in and some of them light up when you talk about research and they're like, oh my gosh, I'm all over it. I've got all these ideas and how can I help you? And then other residents aren't interested at all in doing research when they come in the door. How have you found your ability to stimulate interest in research in perhaps students that haven't done it in the past and don't really understand the value of doing research?
I will say that probably honestly, anybody that's coming to the residency program knows that this residency program is there, So I think people that the residents that are dedicated to research want to go that extra step in it. They know that this is one of their top choices to be able to go to this residency program because of the research aspect of it. So that one is kind of, it's just there, and it's almost somewhat expected of you that you're going to be a part of research with it. But I think once you get to any residency program and you start to see that you're trying to answer questions on why we do something, that there is an aspect of stimulating all residents to want to do some research. The aspect is the time factor of it. It really does take a lot of time and dedication, and you are required to, do a lot of different rotations and be in a lot of rotations and learn a lot of things, and rightfully so, that sometimes research gets pushed to the back of things in terms of doing it. And it really takes some time. It means at night and on weekends to try to do these things. So that's the aspect of trying to get it done during a residency program. And certainly I was able to do a lot more research in my career during fellowship, where it wasn't like you weren't on call, so you had more time. And once I got as an attending, but it was very difficult in the high volume residency program where we did a lot of surgery and there was a lot of time expected for us. It was very difficult to be involved in research or do any research. And kind of the research that I did and that I was really interested in during my residency program, I had that data, and it was probably 7 years after I graduated did I finally take that and actually go and publish it. So it was kind of holding on to it, but it just wasn't a lot of time to be able to do it. So that's the hard thing about research. It's excellent. It just takes time to do it, but having some involvement in your residency program is excellent, and it brings you a long way to be able to be a fully rounded podiatric physician and surgeon.
I think it's interesting that if you get a room full of curious people and you do a simple journal club and you review a few journal articles, ideas start popping and people have new ideas and how can we expand upon this? And I found that one of the best parts of journal clubs is the potential that can go from there afterwards.
Yeah, and it is. And it's, taking that and even going and critically looking at that piece of research to say, if you were to do research, what are the positives and what can you bring out of it and make it better in terms of research for you? What could be done differently? And I think that's what really makes it to go over journal articles, is to kind of get the idea of how something's written so you can not only understand it and use it, but how do we take that information to, if you were to do research, do it in a way that might be able to portray the information a little bit even better.
Well said.
Yeah, and it's interesting. We had talked with Hiro Shibuya about research, and what was interesting to me when I asked him, like, how did you get interested? It was that curiosity, right? Like, he was kind of just poking the bear, like, is this really the best way to do it? Like, why do you say that? And help me understand why this is the best. And I love that you had mentioned that, like, that curiosity. It's just, is this the best way? And if it is, what other questions can we ask? Or, okay, so we found that this is maybe the best way to do something. Are there alternatives? Are there other ways? Are there other, strategies or risks that we need to consider? And it, as Jeff just said, kind of just starts to, circle around and up questions.
Yeah. And I was at an event just this last weekend in Las Vegas, and I heard Mindy Dayton was talking, and she said, we're talking about getting wounds wet after surgery, post-surgically. And they were like, we were taught that you can't get incisions wet. And, Paul and Mindy, who are excellent researchers, said, well, let's look into this across the board. And they're like, there's nothing that says, we were just taught that you can't get an incision wet after surgery when you have sutures in. But it's not actually what's there. And you go and look at the literature and then write something up and say that this isn't the way. So that curiosity is what pushes it to kind of get an answer. When you kind of sometimes say, is this really the answer? And it doesn't have to be research that allows you to make that decision. It could just be something that you're in surgery with one of your attendings and you're like, why do we do this? And the attending might be like, oh, we've just always done it that way. And some very curious students, residents, fellows will say, well, how? How do you know? What do we do? And then when you do research to see if that's actually the truth or not.
Yeah. So piggybacking on that, exactly like you said, and then earlier in the conversation, you had talked about students can be very tactful when they highlight to you that maybe your recommendations are maybe not as up to date as you think they are. What about, have you had any interactions where students maybe are not as tactful? One of the things that we talk about is kind of highlighting qualities of a good student. How do I shine on externships? And a common theme that we're starting to notice is kind of emotional intelligence. Can you give us some insight in terms of things that you've seen and what your experiences are?
So I can give you on two different aspects, some really personal aspects of during times that I was a student. Okay, so we're going back a long time. And I think they really kind of hold the test of time. We have a very interesting profession. And why I'm saying that is there's not many other professions. And I say this to students all the time that come in. And when I'm ever at I work with students at the Shoal College because it's close to here in North Chicago, is that we have a profession where you're on a 30-day job interview, which is kind of interesting. Because we end up choosing, for the most part, most residency programs, you're going to choose people that came and spent a month and did things. So the bad thing is on that, it's a good thing because people can see you. But the bad thing is it's kind of like you have to be on, for lack of a better term, your best behavior the whole time. And so there was a residency program that I really wanted. And I was there and I was working very hard. And I had a very tumultuous relationship with the other student that was there on that same month. And that student really kind of was trying to make me look bad, or just in such a competition. It was so hard. And I tried every day. And then one day in surgery, did something come up, and I think it was putting a tourniquet on a patient or doing something. And I couldn't handle it. And I snapped on that student. I said something and I was like, you got to get off. And I don't even know what I said. It was a long time ago. But anyway, the chief resident pulled me out after the case and said, Jeff, you have to understand that the operating room is like church and you have to be good in the church. And I said, okay, thank you. And I understand that. I did not get asked for any interview. And it was like the place, and it devastated me. And it was like every day. So, you're on a job interview each day. So what do you do? So one of the things in terms of my recommendations of this is you kind of have to just do a good job and be there every day and be attending, be interested in the cases, be there watching and otherwise. But at the same time, you can say something. So you don't have to just sit back and not do anything. So the other example that I had was that a residency program where I was on my externship at the time, and I was watching this tibiocalcaneal nail case that they were doing. And the attending and the resident were struggling, and I was just sitting there, and I just kind of shut my mouth. It's not my place to tell them what to do or otherwise. But they were trying to put a screw across the tibia, but they had left the guide wire in. So the drill wouldn't go across because the guide wire was still in. And I just sat on my hands for probably 15, 20 minutes, and I didn't know what to do. And I finally said, well, the guide wire is still in, maybe we try that. And they were like, why didn't you tell me that 20 minutes ago? And they were so happy about the fact. So there's this in between of like, you don't want to do too much, but you got to do. So those are two of my examples of it. In terms of in general, we see, the students that come in and work with us in our residency program. It's the ones you can tell the people that are asking questions and open questions and use the situation that's going on to kind of say, hey, I want to learn a little bit more about that. Why do you do? And the students will just say after the case, Dr. Baker, can you explain why you did that and otherwise? And those are the students you really kind of remember for and when things come up is the ones that really do are interactive, want to be involved, show up. There is nothing you can do in life, has nothing to necessarily do with podiatry. There's nothing you can do in life than be on time, like better than that. Like that's the simplest of things of anything, but you're there, you want to be there, you look like you want to be there, you're not causing problems for, saying other things. So that's my kind of long-winded answer on what you would ask about situations of it. Some of it personal about what we do now in terms of with students that come in and the ones that we really remember and think about this person, if they have an excellent interview with somebody that we would like to spend 3 years with.
I like that.
I think those situations are so hard when like the other student that you're with is hyper competitive. This is actually something we haven't talked about yet, Jeff, but I think would be this is a great opportunity to kind of expose some of that, because these dynamics are, as you said, Jeff, you're a month-long interview, right? You're trying to put your best face on, and then you have somebody there that is just poking the bear, right? They're just trying to find ways to maybe make you look bad or show you up every time.
Absolutely.
And that's a really good thing to talk about, because I think we have all had similar experiences, or we've watched it happen. I can tell you from watching it happen, right? When you're seeing this dynamic between students, true colors start to show. Like you can tell when there's one that's picking on the other one a little bit more.
Yeah.
I don't know. I don't have much to say, but go ahead.
Yeah, because it's tough in terms of what do you do? Because again, it goes back to the first thing I said. You're both on a job interview, and sometimes there's only so many spaces, so you got to show yourself. But just being the best you can be and good. I think I always say that things come back to haunt people, and not that I wish the worst on anybody, but I'm sure if that aspect of things, that potentially that student that I was working with, potentially, had other issues in terms of other things that they tried to do. And I didn't handle it well. I'm not sitting here saying I handle it well, because I didn't. I learned a lesson from it that I still tell the story about. That was in September or July of 1999. So that I remember it that much, 25 years later. But it can make a difference on things in terms of how you react. So it's just weird, because you always, in life, you have times to make a mistake here and there, and it's all forgiven. But it's this weird little scenario that we're in with podiatry that kind of is like, even some of the, MDs and DOs and how they do things isn't the same as, because we're just so small. Everybody thinks it's podiatry is big, but it's really small, which goes to the other end of it on things that happen. That I'll just say one thing about it, as like in podiatry, like pretty much everybody knows somebody that knows somebody. So you gotta be on your, it's gonna come out. And that's more on after you graduate from residency program. It's a bigger aspect when you're looking for a job, and then you're looking for another job, because someone is going to ask somebody that's going to ask somebody. And if you have been nefarious in some of the things you've done in terms of how you treated patients and other people, it's going to come out. You're going to be like, why didn't I get a job or otherwise for it too? So it's a small profession.
Jeff, having this discussion, and Joe, reminds me of when I was coaching kids, when my kids were little. I used to have 3 rules: do your best, have fun, have good sportsmanship. Good sportsmanship could be like behave, treat other people the way you want to be treated. It'd be very hard to be on the receiving end of a bully, if you will, that's a colleague. And I think the colors shine. And another thing that just came into my mind was, you need to be good at all things that require no talent. And sometimes that's just sitting back and relaxing, being on time, asking appropriate questions, being quiet when you should, except for the wire that was preventing the fixation from occurring.
Yep. It was. And they loved me. And I went into that residency interview, and it was the greatest residency interview I've ever been into. And it was in a city that was like, I wanted to go back to the East Coast. I was in Ohio. It was a residency program in Ohio. It was an awesome residency program. I loved everybody there. But there is an aspect that you wouldn't do as well on your job if you're not happy where you're going to live. And I grew up in a small sort of city, medium-sized city, Albany, New York, capital of Albany. But I always I went to college in Boston. I did my I was going to big cities. In some small little city, I was just not going to survive. And I went in there and they're like, Jeff, if we gave you this residency program, would you take it? Could you even live here? And I was like, no. And they're like, okay. And they just talked to me during the residency, interview afterwards. I'm like, no, I can't, thank you guys for that. And I'm not wasting anybody's time or anything else because I was there as an extern during that time. So they give me an interview. I was just like, and so that was kind of it, which was kind of good because maybe I had a great month there and said these things and otherwise, because I didn't have myself under a lot of stress, because I was like, it wasn't like, and then one of the programs that I really want to, and potentially my top choice, I never got an interview for because I was just so stressed out under the circumstances of it. So there is an aspect of bringing that up, Jeff. It's like, I had a great month because I was sort of laid back and I was there every day and just working hard and it was good. But that's what having a good team and the environment was just so much better. Just the city that was in is just not somewhere that I think I would have survived in terms of 3 years of working hard and not being in a big city and otherwise just wouldn't have done very well for me, as opposed to ending up in Hoboken, New Jersey and outside New York City, close to where I grew up. It was an excellent environment for me to thrive as a resident.
That's great. Jeff, you did a fellowship way before they were popular. Joe, you okay if we shift gears into fellowship discussion?
Yeah.
So, Jeff, that's a huge topic right now for our students. Even when they're students, they're debating if they're going to do a fellowship after their 3 years of residency training. Your thoughts on your fellowship, the current trend to more fellowships? The floor is yours.
So, I had somewhat of a medical background going into medicine, and that was being an athletic trainer. I graduated as an athletic training major from Northeastern University, and then I worked at a high school as the athletic trainer for a high school in Massachusetts for 4 years. With that, I had a lot of interactions with medicine, and most notably with orthopedics, because they were the team doctors and otherwise. But all the orthopedic surgeons that would do surgery on my athletes or that I'd interact with or I sent with, they were all fellowship trained. Like that's the way you get your extra year of specialized training. So even though at the time of my graduation from residency in 2003, there weren't many fellowships, to me, it was ingrained in like fellowship is the way to subspecialize yourself and go into another aspect. I got into podiatry because of the fact that I had a podiatrist who was the parent of one of my students at the high school that I was the athletic trainer, and I was looking to do something else and sports medicine wise and said, look into podiatry. So it just was baked into me, that fellowship and that actual year of training. And so when I graduated in 2003 from residency, looking into things, I looked into some jobs, but I was kind of like, I looked into fellowships because I thought that was the normal progression. And I actually, at that time, I don't mind saying it, as I took a pay cut from what I made in residency. I've actually made less as a fellow and a resident. So, but it was the fact that it was the greatest choice that I ever made to go to the Weil Foot Ankle Institute, train under Dr. Weil Sr., Dr. Weil Jr., who was my fellowship director, and get that extra year of training. It was a lot of interaction with ACFAS, more than I was involved in before. Everything of where I am in terms of as a current podiatrist, I can track back to my fellowship. So I think that it's an excellent choice. And I always say to look into fellowship. And I think fellowships in podiatry have even done better than they were when I was a fellow, because they're coming more subspecialized. So you get a subspecialty within a subspecialty. And I like the fact that there's some, you say, you want to do research, here's a fellowship. You want to do reconstructive surgery, here's a fellowship. You want to do sports medicine, here's a fellowship. You want to do limb lengthening and deformity correction, like my wife, who's a podiatrist and did her fellowship in Baltimore with Dr. Brad Lamb. She is subspecialized in that, to the point of now, any patients come into my office that needs those sort of things, I send to my wife's practice. We don't work together, but she works in another practice and we send it. So that's the ability to subspecialize has made it an excellent aspect of our training. And I think that people that are really motivated and want to go to that next step. And I don't want to say with saying this, like that in any way, shape or form that everybody has to do a fellowship to be considered. Otherwise, there's excellent people out that have done just a residency program out in practice and do amazing. But to really get subspecialized, get into that extra aspect of it, and some aspects of it for the medical community to kind of say, oh, they think that most people that do surgery in this day and age, if you're a surgeon, you've done a fellowship in something, and most other aspects of it. So I couldn't say more about fellowships and how I think that it is amazing that we have upwards of 60 fellowships now, and that students are thinking into it. My advice on things is that if you want to do a fellowship, you really should look at it early. So I think that the fact that you have students that are already asking about it is excellent. So it's got to be within think about it in your first year of residency, really put the effort in during your second, because it's kind of like halfway through your second year, these decisions are being made. And so it's really an early on approach for it, but I have nothing but great things to say about fellowship and fellowship training. And I'm very proud of the fact that I'm one of several people that were a part of 4 or 5 fellowship programs a while ago, and that, everybody's getting fellowship trained, or most people are. And I think that's a good thing, not something to say, oh, I can't believe everybody's getting fellowship trained now. No, I think it's amazing that we have this.
Tremendous opportunity. And there's not many times in your life when you can take an advantage of an opportunity like that. Like when the fire's hot, you got to jump in.
Yeah, it's great. And it's very competitive, and that's a good thing, but it's really being involved early on. I will say the one thing about fellowships in podiatry is most of the time you're working under one person, and it's really getting to know that person. It's much more of a one-on-one thing in terms of a fit. Like, I said that a residency program has to be a fit, and it's got to be a city that fits. I will say that fellowship programs are a fit person to person. That fellowship director and you going into that fellowship, there's got to be a fit for that. It's much more of that type of relationship, and especially when there's less of you that are going to be there, as opposed to the residency program where it's sort of in a big extended family, and then it comes down to you're an only child, maybe, in terms of how it is. Okay. So that's the one thing about fellowships is there's a lot more. So if you think there's a fellowship you like, look them up, or whatever fellowship kind of category you want to be in. It's kind of knowing those doctors and kind of reaching out to them even early on as a student. Hey, I'd love to come by. I'd love to do this. I'm about to graduate. I'm thinking about doing this. I got a residency program coming up. There's no time that it's not early enough to do it. And there's been some fellows at the Weil Foot Ankle Institute that were started reaching out, when they were first years in podiatry school to us. And it's 7 years later, and they apply, and you're like, well, I've known this person. They have all the accolades and stuff, and they become our fellow.
I know they also do the ACFAS fellowship breakfast. I know a couple of fellowship directors have spoken highly of that. What is your take on something like that, where you have a whole panel of people?
I think it's excellent. And it's trying to get it so that sort of the one thing about it is when you're looking at all these fellowship programs is it's not as, I wouldn't say organized, but it doesn't make it as easy for the fellowship candidate because you got to go all over the place and stuff. So the fact that they're having fellowship breakfast, they're looking to kind of coordinate, and some of the fellowship programs have had it. So all of their interviews are at the same time. So you're kind of like applying to 5 fellowships at the same time that have some connection of it. Those sort of things that make it better for the residents, especially when residents are employees of hospitals, like to just be able to kind of take time off. If you're trying to apply to all these, it's kind of difficult to do all of this. So I think that that's a good thing. And the fellowship breakfast is the best way to kind of really decide. And I can remember back that I was with my wife she was in her second year of residency. We went to the fellowship breakfast and she was like, I just want to do a fellowship. I want to do a fellowship. And she had gone and done a medical mission to Honduras during her residency. She's like, I don't know which one. And I saw Brad Lamb walk by me and he's got a deformity correction. And I just said to her, I'm like, that's your guy. I'm like, go meet him. That's where it's that. And that's what I kind of said before. It's kind of like, I knew it would kind of mesh together. And now that's what she does and enjoys doing is deformity correction and limb lengthening and Charcot reconstruction. And she's really subspecialized into that. And it was like, there's just a mix. So that fellowship breakfast is amazing at the ASC and really can get you an idea of like, where do I really want to go and what fits for me?
Fantastic. If we can stay in the ACFAS theme for a little bit, since you are the Midwest region president, for the audience that's listening,
here's the thing. I think I didn't update it yet. So I'm not the Midwest region president anymore. I'm the region's president's council chairperson now. So I'm on the board of directors. So I made the one step up from that that had just happened at the ASC, and I don't think that I gave you the updated information on it. So I was the Midwest region, president for 3 to 4 years, and now I'm the region president council chair, which kind of coordinates all 9 of those regions and all the presidents. I kind of run the meeting that all the presidents have to make decisions on the regions for ACFAS.
Fantastic. So I was going to say, if you can help kind of highlight the hierarchy, kind of how the board is structured to kind of, as people are listening, we have a lot of student engagement with ACFAS. So if you could talk a little bit about those positions.
And so ACFAS has regions, and there's 9 regions, and they're not broken up by number of states. They try to break it up so there's the same number of members in all of those. And of those 9 regions, I think 8 of those 9 regions have 1 or potential 2 of the 11 podiatry schools that there are now. Okay, so becoming a student member of ACFAS is excellent. And if you become a student member of ACFAS, that allows you to have support from the different regions. Most notably, that support comes through manuscripts and posters. So if you were to have a manuscript or poster, then and it gets accepted for presentation at the annual scientific conference, then the region can provide support. It can be $250 for a poster to $500 for a manuscript to help defray the cost of attending the meeting. And then each of those 11 schools, they also get money from each of their respective regions to have the region officers be able to go and actually be a part of the annual scientific conference. And then ACFAS likes to take those students and have them, we'll invite them to different sort of events and stuff so that you can see the inner working of the governance of the American College of Foot and Ankle Surgeons. So that's the region aspect of it. And then the board of directors, there's, a president, vice president, the president-elect, and secretary-treasurer, I should say. So president, president-elect, and then secretary-treasurer, they're on the executive board. And then there's board of directors who go through a process of a nomination, and then there is an election to get onto the board of directors that you stay on. So that's the aspect of the hierarchy of it. And the region president's council chair, which I am, is one of the board of directors on that. So I go to the board of director meetings and make help to make decisions to run the college as a whole for the members, because the key to the college is being there as a support for all the members. And members are student members, so we are there to support all the student members. And you can always reach out to any one of the regions. So the region that's within, not where you were from, but the region where your podiatric medical school is. And you can always put in an inquiry that if you had some research project or something you were looking for support for, that the region may be able to have funds to be able to support some research or otherwise for you.
That's great. The American College of Foot and Ankle Surgeons have been unbelievable, and they even contributed to our Feet on the Street student recruitment initiative this year, as you know,
Yes.
Jeff. And we're really appreciative of their efforts. Just a quick little story. We had a prospective student in Knoxville, Tennessee, couldn't find anybody to shadow. One quick call to Michelle Kennedy, and she had 3 doctors, all affiliated with ACFAS, that this prospective student could go visit and find out about podiatry. And it's just wonderful. So I thank you and ACFAS for all you're doing for the profession.
Yeah, while we kind of talk about all of us as podiatrists that are on the board of directors, otherwise, the executive director down through all of the staff are excellent at ACFAS, and their goal is for for foot and ankle surgeons, podiatric foot and ankle surgeons, to be the best that they can be, and that's from the practitioner that's been in practice for 50 years all the way down to a prospective student that wants to get into podiatry.
It's fabulous. Can I shift gears again, Joe? Different topic?
Yeah.
Sure.
So I'm interested, and everywhere I go around the country, docs are talking about different groups they're joining. So there was a merger between Balance Health and the Weil. Can you talk about joining of supergroups, formation of supergroups, the pros and cons of supergroups? Because that's another question we're getting every day from the students.
Okay, well, that's very good that the students are looking that far into the future to kind of think about it. But this is not a podiatry phenomenon. This is a medical phenomenon. That's the biggest thing that I kind of say. And I actually think podiatry is behind on this, not behind in a bad way, but it's just coming to podiatry later than it has to everything else. Okay. The mom and pop medicine is just kind of going away in general. And that is from your internists it started with and all the other groups that are kind of merging. So this phenomenon is just the nature of medicine in the United States. I keep going back to situations with me. My analogy that goes along with this is when I was in high school, my first job that I ever had was working for the local pharmacy in the village that I worked in. And we had a pharmacist that went away to pharmacy school, came back, and he was the pharmacist in our town, and I was the delivery driver for him. This was probably 1992, so a long time ago, was pharmacy changing, and he had to go and work for CVS because he just couldn't survive anymore. And so that analogy is like a long time ago, but mom and pop physicians, the same thing is happening, being able to work for yourself. It's hard to get on insurance contracts. So why are you part of a super group? You have the ability to get on insurance contracts better because you're a big group and you add on. You have buying power. So when you buy a product, such as a cam boot that you have to give to a patient, if you can only buy X amount of cam boots, the cam boot company is going to be like, well, we're going to charge you more for that cam boot, as opposed to we say, well, we want to buy cam boots for our 7 state worths of offices. You can work. So it's little nuanced stuff that allow for you to be able to efficiently treat patients and still keep the doors open. It is a way other soapbox of things of how we're in the United States of America and we have a for-profit health system, which is a whole other story and things. But it is the fact that everybody's going to work for a business. There are some people that may work for nonprofits or otherwise that aren't looking to do that. But unfortunately, your boss, and even my boss currently, I'm not my own boss, is a for-profit industry. So that's why you end up going into supergroup. You have the ability to do better marketing to get patients to come into the door. You have the ability to offer better salaries to your employees, which make you work better and more efficient so that you can see more patients. So there's just so many positives. The potential negatives of it are there's some lack of autonomy. So the aspect of saying, I'm going to work this day, this way for these many hours. And it's kind of like, no, you're going to work this day for these many hours. Okay. Which is, when you owned your own practice and had the ability to do that, you do, but you end up to be an employee. And so it's just like any other job that you're an employee. So sometimes it's, you're going to go and work at this hospital or this office or work these hours or going to see these things. Or, even though we talk about fellowship and being subspecialized, it's more about, well, you're going to see everything that if a patient needs to be seen, you're going to be seeing it, even if you don't regularly treat that. And then you, as an internal referral within the organization, you get it out to the other one. So we end up to be like gatekeepers, like you just have to see. And that's kind of no different than it is in most other sort of professions, or even how internal medicine is now. And most of them work for these major health systems. And then, so that's kind of the ins and outs of it in terms of private practice. But it's kind of like survival, and it's just very difficult to survive being on your own, just on a street corner, and trying to deal with behemoths of health systems, but even now behemoths of podiatry practices in terms of private practices. So I think it's been very positive for us in Weil Foot Ankle Institute and Balance. I've interactions in the meetings that we have, and we have, we'll have education meetings where we have 80 to 100 doctors on a Zoom call going over things, and you hear the West Coast version of it. We keep always say, oh, we do this on the West, we do this on the East, and it's kind of good. And I think we're going to plan, and sometime soon we'll have our first in-person where we're big enough to have sort of a conference among just us, which is kind of excellent too. So there's a lot of positives about it. I think it's more streamlined. But I think the negatives about it are people that have been in practice for a long time that own their own practice. I think the graduating people, it's like whatever job you go to, they're going to say you're going to work this many hours and see this many patients. So I don't think that changes on our upcoming graduates. It doesn't. I think anywhere you get a job, there's going to be some aspect that it's kind of for efficiency's sake and otherwise, that there's going to be an aspect of like you're not going to be able to choose so much about what you do per se.
How many docs are involved in the group right now?
I think we're up to like 160 providers, going towards 200, but we're adding practices around the country on a pretty regular basis in terms of acquisitions of that. So we have some, we're in, I think, 7 states now. The one thing about it is, which has been good on a podiatry aspect of it, is the practices that we take in keep their name. So Balance Health isn't kind of anywhere. You can't kind of see that. So each of these practices that join, like Weil Foot Ankle Institute, still Weil Foot Ankle Institute. So you have all these different brands that are underneath it. So that makes it good. So for the patients, like nothing's changing for these practices that are joining us. We're not getting a new name or otherwise for a large majority of them in different section. Depends on different things. But in different areas, we're kind of keeping the bigger name that's in that area to kind of keep that going from a marketing standpoint.
Very good. Thank you.
And actually, if I can just jump in on that for just a second, because I do think, to your point, Jeff, this younger generation of doctors that are coming out, they're not as concerned about, I want to own my own practice, I want to hang my name up on the board. They are a little more concerned about, I want to make time for the other things that are important in my life. And so I'm okay trading off somebody else managing all of this stuff, right?
Yeah.
If I want to go on a vacation, I have 4 or 5 other partners that will help manage my patients when I'm gone. So again, there are trade-offs, certainly. And to the idea that you still do have some, it's, you don't have to change your name. There are more flexibility options than being employee number X, or at, big box medicine place. So there is a little bit more flexibility, autonomy than being an employee of like a hospital per se.
Yeah.
But you still have responsibilities of yeah, you can't take every Tuesday, Thursday off by 2, like there's some rules you got to follow. And I think they are much more open to those kinds of trade-offs. So I think it's an exciting alternative to like a hospital-based practice for people that still want more of a private practice feel.
Yeah.
But just being able to negotiate better EMR rates, right? I mean, it's insane what some people, like when we were in a private practice, like the cost, because it was 2 people and they're like, sorry, we can charge you whatever we want. And I'm talking with some friends and they're getting like 3%, 2%. I'm like, there is no way, like there's no way we're ever going to be able to get there. And it's suffocating because of all of these fees and then all the Medicare requirements. And it makes it very hard when it's a small independent practice to check all the boxes all the time. So I think it's a good option for a lot of people.
Yeah. And we still try to keep it. So that's why we let each of the brands, for the most part, kind of keep their name and otherwise. One of the initiatives we do, so we have to be a big practice because we got to be under this big umbrella, but we want to still make it like we're the place down the street. So we actually don't require, but we kind of suggest, and I actually do this, and I've been doing it for 3 years, and it was suggested of Dr. Weil Jr., that every new patient that we see, we write a handwritten note to them to say, thank you for coming to see us. So it ends up to be very, and he had heard that through some other people and some business groups that he's a part of, that it works very well, but it's an organic and very inexpensive marketing tool. But, people they don't want to be a part of a big thing. They want to shop local and otherwise. So it's kind of good. So we're talking about it, that we kind of know that this is this big conglomerate now that's been built up. But for the patients, they kind of think like, oh, you just have like these 3 offices around the city and there's a couple doctors there. And it's kind of that in between of kind of getting that feel that, they're just, the patient's not just a number. So we try to do some things on that aspect too for our patients and newsletters and otherwise to try to keep it to be like, this is your around the corner podiatrist.
Very excellent. Jeff, we're running a little short on time, and I can't imagine that being a medical director, training residents, and seeing patients is all you do. What do you like to do when you're not involved in podiatry?
Spend time with my son and my wife. I got a 5-year-old. He's great. He's the love of our life, and we do all kinds of stuff with him. We live in the city of Chicago. We love living in the city, and there's a lot for us to do here. He likes to go onto the train. He likes to go downtown. He likes to go out to dinner. We go out to eat every Saturday night. So it's just spending time with him. He's a blast. And then you had mentioned before that I had played college soccer, and soccer I just love and have played my whole life. And so I still play adult competitive recreation soccer, but on a German team. So I play on an over 48 team, and we play 1 to 2 times a week. I play on a German team. We play against Croatian teams, Polish teams, like all these big clubs, Lithuanians. So I play a lot of soccer. So I continue to play soccer, and it's what I enjoy more than anything else. In terms of athletics, so I keep playing. So those are the things that we do a lot, but we really explore the city and use the city of Chicago to our advantage, and then playing soccer and spending time with my family. So I have that as Joe was saying, like there's got to be time after work to be able to do those things, because it makes you a better physician having a good, that you're happy in life and have a great life that you want to go home to afterwards.
Absolutely. Joe, anything else on your end?
No, that's a beautiful closure right there.
I agree. Do you speak German, Jeff?
No.
Oh, I was wondering maybe German team, German red card. I was wondering what that is.
We have so few Germans on our German team for some reason, but yeah, it's like 55 years old. These Germans came over and started in Chicago, and now they have youth divisions and all the way up to over 48. So it's just some people that I met and German team, but the German team is sponsored by Weil Foot Ankle Institute. I will say that is on the front of all of our uniforms. So yes. So when we make a thumbnail for this YouTube podcast, can you send me a picture of the uniforms and your team? Yeah.
Okay. All right. I think that'd be awesome. Some Weil Foot Ankle. I love it. All right. Well, gosh, Jeff, we really appreciate you taking time out of your busy schedule to join us. We're going to send you a Dean's Chat cup that you can drink your beverage of choice out of. And you're welcome. And of course, all of our listeners out there, if you're on Apple or Spotify, please give us a 5-star rating. And if you're on YouTube, by all means, please become a subscriber. And until next week, cheers, everybody.